Hello, everyone. Dr. Yonit Arthur here. You are on the Steady Coach, and it is my great honor today to bring you this interview with Dr. David Clarke, MD. Dr. Clarke is one of the great leaders in our field, and as a practicing gastroenterologist for 25 years, he saw thousands and thousands of patients with stress illnesses, or what we now know as psychophysiologic disorders like chronic dizziness and chronic pain. He indeed worked with many people with vertigo and dizziness. And in this interview, we specifically dig into his experiences with those kinds of patients and his view on the path to recovery. We also dig into his specialty, gastroenterology, and discuss stress illnesses, or in other words, unexplained symptoms that occur in the gastrointestinal tract, including IBS or irritable bowel syndrome, heartburn, and others. And he explains why these happen, why these so frequently occur with other types of psychophysiologic disorders, and again, how to recover from them. So, just to give you a sense of Dr. Clarke's many accomplishments, Dr. Clarke is currently the president of the Psychophysiologic Disorders Association. He's assistant director at the Center for Ethics and clinical assistant professor of gastroenterology emeritus at the Oregon Health and Science University in Portland. And he is associate faculty at Arizona State University, associate faculty at the Cummings Graduate Institute, clinical advisor to SERPA, which is the Stress Illness Recovery Practitioners Association in the UK, and clinical lecturer with Pacific University in Oregon. So Dr. Clarke is board certified in gastroenterology and internal medicine as well. You can see he's a very busy man, and it was such a privilege to use some of his time to speak to you all on his experiences with dizziness and vertigo specifically. So please enjoy this. And again, if you have any digestive problems, you definitely want to listen all the way to the end of this interview. And of course, as always, if you enjoy this interview, please subscribe to my channel, please share, and I look forward to your questions and comments below. Enjoy. All right, Dr. Clarke, we are live, and I am so grateful that you agreed to come on and talk to me today.
Glad to be here. Appreciate anybody who is able to spread the word about this very important condition.
Mm-hmm. As we all do. Yes. I'm so, again, it's the appreciation is mutual, especially given just how much you've done for our field. So I'd love to start before we dig into some of the topics that I wanted to talk about today. If you could just share a little bit about yourself, your work with mind, body, or stress illnesses, and what you're doing for the Psychophysiologic Disorders Association.
Okay, well, I'm a physician and board certified in gastroenterology and internal medicine. And I encountered my first patient with physical symptoms that had no biomedical explanation in 1982. Very severe symptoms that woman had, and I had no idea what to do for her, and which came as a shock to me because I was in the 8th year of my formal medical education and training. I had been doing well up to that point. I got an award for diagnostic excellence in medical school. I got into a top residency training program at UCLA. I was passing my board examinations with flying colors, and all of a sudden in the 8th year of all this, I encounter this patient who, she was moving her bowels once a month on the average for 2 years, was taking double the usual doses of 4 different laxatives, and it wasn't working. Now, I know this is a long way from vestibular disorders, but don't worry, we'll
get there.
We're gonna get there. And I had no idea what to do for her. I mean, she'd already been evaluated by another university. She came to us for some specialized testing that we did, which we were sure was going to be abnormal because there was no other test left to do, but that test was normal. And so I was kind of doing her exit interview and stumbled onto the fact that she had been struggling with a severe stress. And didn't know if the stress could possibly be connected to her illness, but I thought at least, this gives me a way to pass the buck. So I sent her off to a psychiatrist that I knew who was also board certified in internal medicine,
Mhm.
and thinking, nothing is ever going to come of this. You can't talk somebody out of an illness like that. But I ran into the psychiatrist a few months later in an elevator and found out the patient was cured. And that just upended my world. The idea that you could alleviate serious physical symptoms just by talking to somebody, by an entirely different diagnostic approach, was a shock. It was like finding out, if I was a math PhD, that there was something called the multiplication tables, 6 years in. So I, prevailed on Dr. Kaplan to teach me how she thought about this, what her approach was, what was the framework she used, and thinking, it might come in handy for a couple of patients a year when I got into practice. Well, that was the second area in which I was completely wrong, because without even trying, I was seeing 5 or 6 patients a week in just an ordinary, otherwise garden variety practice of gastroenterology. That people had these mind-body issues, these psychophysiologic issues that were capable of causing almost any level of severity of physical symptoms. And even worse, there were no Dr. Kaplans in Portland, Oregon, where I was in practice. And so when I sent them for mental health treatment, they would get cognitive behavioral therapy, which usually isn't anywhere near good enough. And the patients would come back and say, I'm still ill. What do we do now? And I tried to help them. I thought, I'd seen Dr. Kaplan do it. I knew how she thought about it. I mean, I was a bumbling beginner for a number of years, but even as a bumbling beginner, I was getting better outcomes than these patients were getting from the rest of the healthcare system. And I gradually got better and better. And as people became aware that I was willing to see patients who had these profoundly difficult conditions, they started sending me patients who did not have purely gastrointestinal problems. They had problems from head to toe, sometimes along with gastrointestinal symptoms and sometimes without. I eventually wrote a book about this for patients, and as it turned out, the very first patient described in that book had attacks of extreme dizziness, accompanied by nausea and vomiting, that were happening 6 to 10 times a year. And she was hospitalized at one of the best universities on the West Coast. She happened to live right nearby that hospital. And she had roughly 60 hospital admissions to that place, saw over a dozen specialists, including a psychiatrist, and they still had no idea after 15 years what was wrong with her. But even though this was like 1980 something, 7, 8, somewhere in there, that I saw her, I knew what to look for, found the connection to stress in her life, which was huge. And just bringing that into conscious awareness in her case was enough to alleviate the symptoms. I wish I could claim to get results like that with everybody. I mean, at the other end of the spectrum, there are people that need years of psychotherapy to get the same outcome. But in her case, the cure was pretty much on the spot. She went home from the hospital the next day. She called me a year later to say she'd gone an entire year with no attacks. And after that encounter, I went home and told my wife, I am really onto something here. And it just became 1/3 of my practice, a very important part of my practice for 40 years.
Mm. Wow. First of all, thank you so much for sharing that story. I have shared your book with countless people, so I will link to the Amazon link below in the description of the podcast or the video. They can't find anything wrong. It's wonderful, and what I love so much about it is you talk a lot about these other conditions, because in our field, frequently people are talking about chronic pain. And my folks who watch my YouTube videos and people looking for my help don't have necessarily pain as their primary concern. They have dizziness, they have gastrointestinal problems, they have other medically unexplained strange symptoms that just came out of nowhere seemingly and are not alleviated by conventional medical treatment. And you talk a lot about that in the book.
Yeah, absolutely. The only common denominator in patients with mind-body disorders, or what my colleagues and I call psychophysiologic disorders, a blend of psychology and physiology, is that the
Mhm,
patients tend to have more than one symptom at a time. They
mhm,
don't always, but they often do, and it can be pain almost anywhere, but it can be non-pain symptoms too, literally
mhm,
from head to toe. So it can be
mhm,
ringing in the ears, it can be dizziness, it can be
mhm,
visual disturbances, pseudo seizures, difficulty swallowing,
mhm,
difficulty breathing, chronic cough, all kinds of gastrointestinal symptoms other than pain,
mhm,
genital issues, pelvic issues,
mhm,
numbness and tingling in the extremities. Um, and again, it's quite common for people to have more than one of these.
mhm.
One of my patients, my personal record patient, had 27 different symptoms. He came to me with a printout from the internet, and he had circled all the symptoms that he
Oh
personally
my
was suffering
goodness.
from. 27. And the good news with him was that he was, all of them were successfully treated in a very short space of time. A little over a month in his case. So
Mhm.
the number of symptoms, the severity of symptoms, the duration of symptoms doesn't necessarily correlate with how long it takes to get better.
Thank you for
Once you
saying that.
connect with the stress.
Thank you for saying that. That's a question I'm asked frequently because, unfortunately, in the vestibular disorders world, which, as you and I discussed offline, there is a lot less awareness of this particular framework of this idea of a psychophysiologic disorder. And people are often told once you have it for 6 months, once you have it for a year, you're just stuck with
It's
it.
chronic.
It's chronic.
Yes.
It's gonna stay forever. It's
You
incurable. It's
just
an
have to learn to live with it. Oh, I
yes.
hate hearing
I
that.
hate hearing that too. Yeah. So it's very natural for people to suddenly feel but they come to me in their 11th month and they're like, "I've got 1 month. Otherwise, I'm stuck with this forever." And then people come on my channel and say, "I've had this for 30 years. There's no hope for me," right? And so that you have just very flatly said that is absolutely not the case.
My personal record patient had symptoms for 79 years, and she didn't get 100% relief. I mean, the neuroplasticity in the brain of an 87-year-old is not what it is even when you're 60. So
Mhm,
she didn't get 100% recovery in the years of life that she had left, but she did very well. I mean, probably 60 to 70%
mhm.
improvement, which, after almost 8 decades of illness, was a pretty remarkable turnaround.
Yes, yes. Well, okay. I so much to unpack in everything that you just said, and I'm excited about every bit of it. I'm just hoping we can come back to the patient with the vertigo because I'm sure everyone's ears perked up about that. And I'm curious if she had a diagnosis. Did they give her a particular diagnosis that you recall? Was she told she had some kind of vestibular migraine variant or Meniere's disease? Do you happen to recall?
And I don't recall that. What I do recall is that when I walked into the hospital room and said that I was there to, do a consultation, she said, "Don't waste your time. uh, you'd be better off seeing your other patients." And I had never heard that from a patient before. I've never heard it from a patient since then.
Mhm,
Here I am trying to help out. I'm a specialist. I'm there to do a consult, and she's kicking me out of the room. I'd never seen that before since. But she had good reason because she'd been through all these diagnostic tests, and I think in her case, they just didn't know what to call it. I'm sure that she got one label or another.
mhm,
She could very easily have gotten, every label that you have on your website at one time
mhm,
or another to
mhm,
try to, because what physicians do is they try to make a patient's symptoms fit into a box that they know and understand. Because almost none of them have had any formal training in psychophysiologic disorders. So it's outside of their conscious awareness as a diagnostic possibility. They don't know how to look into it. They don't know how to treat it. And so what they do is they take the patient's symptoms and try to make it fit into a biomedical diagnosis that they're familiar with.
mhm,
And so I'm sure she got lots and lots of diagnoses over the years. Like I say, they eventually got so frustrated whether they had a psychiatrist come and interview her. But unfortunately, the mental health professionals are trained to look for traditional mental health diagnoses. And she didn't have depression. She wasn't anxious. She didn't have post-traumatic stress. She didn't have bipolar. She didn't have any of the standard psychiatric diagnoses either. So the psychiatrist concluded, nope, she's not mentally ill. Nothing to see here. It must be biomedical. But it wasn't. It just by knowing what to look for, and I can go into a little bit of the description of how she was diagnosed. But what I do is I look for sources of stress, and
Mhm.
I look for stress in the person's life at the moment. I do look for depression, anxiety, and post traumatic stress because those can manifest in the body even more than with mental health symptoms.
Mhm.
So, a lot of people with depression, anxiety, and post trauma present to the healthcare system with a bodily symptom rather than a mental health symptom. She didn't have that. So the biggest thing I look for, and probably the biggest shock of my medical education, was finding out that stress when you were a child could make you ill as an adult. Sometimes after years, into your midlife before these childhood issues manifest. That very first patient with the one bowel movement per month had been sexually abused
Mm.
repeatedly by her father up until about age 12. But now she's in her late 30s, so nobody's touched her against her will for 25 years.
Mhm.
And she suddenly, at age 35, gets this terrible symptom, after a very long delay from the childhood stress. So that's not unusual at all. And in this patient's case, the patient with the severe vertigo and the vomiting that went with it, she had been emotionally and verbally abused by her mother starting at about age 3 or 4. And unfortunately, it was still going on. The patient was
Mm.
50 years old. The mother was in her 70s, and the mother was still emotionally and verbally abusing her on a regular basis. So that was, something that I always look for. Was there childhood stress? Are there triggers going on in the person's present day life that are connected to their childhood stress? And she had, definitely both of those big time. So I knew I was on the right track. So the next thing that we needed to do was to find out if there was anything that we could identify as a trigger for her attacks, because she was having these attacks 6 or 10 times a year, half of them severe enough to put her in the hospital.
Mhm.
And so I looked for something that might be triggering these episodes. And sure enough, she started telling me a story that neither she nor her husband nor any of her doctors, including the psychiatrist, could figure out, which was that there was this little town about 45 minutes from where she lived that would always trigger an episode. And for me, that's a giant screaming clue, because there is nothing about a town passing through a little town that's going to trigger an organ disease or a structural abnormality. It has to be something in the brain that is triggered by this community. And so we spent some time trying to figure out what the trigger was. And I was actually not finding it. And I was getting a little frustrated. And I said, well, if there's nothing about this town that's significant, and you always get an attack whenever you go there, why do you go there? Why don't you avoid it? That seems logical to me, right? And it turned out that she couldn't avoid it because this town was on the direct route to go and visit her mother, which she did, every year, year and a half. So the only time she goes through this town is when she's on her way to visit her mother, who has been verbally and emotionally abusing her for 47 years. And so I said to her, look, I think what's happening here is that you've got enormous emotional tension in your relationship with your mother that you're not consciously recognizing. And when you get in the car and your husband's driving and you're going off to visit your mom, you're starting to think about how terrible this visit with her is going to be. And that emotional tension is building up and building up until that by the time you get 45 minutes down the road, he's got to pull the car over and you're vomiting all over the guardrail.
Mhm. Mhm.
So I thought, this has to be it. There's no question. This should be, bells going off and light bulbs flashing when she hears this. And she was still, thinking about it and saying, really? I mean, because the emotional consequences of abuse can be so buried that people don't consciously recognize it. That's why it gets expressed via the body, whether it's gastrointestinal symptoms or vestibular symptoms, because the emotions are not um, accessible to our conscious awareness. So I had to take one more step to really bring it home to her, which was to ask her, well, what happens if you drive 45 minutes in some other direction? Any other direction, as long as you're not going to visit mom.
Mhm.
And that was when she finally got it. And I still remember to this day how she looked up at the ceiling and said, "Oh my God, I can't believe it." Because she could drive 45 minutes anywhere else. As long as she wasn't going to visit mom, she'd be fine. She could drive
Mhm.
an hour and 45 minutes and
Mhm.
she'd be fine. And
Mhm.
in her case, just helping her see that, just making the emotional issues with respect to her mom accessible to her conscious awareness was enough to alleviate her symptoms. Now she could think about it. She could talk about it. She could go have a conversation with her husband or with a therapist, in which I urged her to follow up with. And putting these emotions into words means they don't have to be expressed, into various locations in your body. And she did great in her case. I mean, like I say, she called me a year later. She'd gone the whole year. She'd even been able to drive through this little town and visit her mom
Mhm.
and deal with her mom more successfully, put some boundaries so that her mom couldn't affect her quite so deeply anymore.
Mhm.
Made a huge difference to her. But it just shows how buried these things were. At the end of the conversation I had with her, her husband, who had been quiet the whole time, looks up and he says, she used to get a lot of her attacks after she would talk to her mother on the phone, which accounted for the majority, if not all, of the episodes that she had when she was at home. She'd talk to mom on the phone and then she'd get ill. And they never put that coincidence together as a
Mhm.
cause.
Mhm.
Again, because these emotions can be so deeply buried. When you're a kid, you can get very skilled at keeping your emotions out of your conscious awareness, especially when you're doing it over and over and over again. So that by the time you get to be an adult, you're, you know, Olympic level emotion suppressor.
Mhm. Beautiful story, perfect illustration of the entire framework of what we do for our patients. I, I'm I'm interested to hear your thoughts on this. So, what you describe, of course, that's such a great story because it's the connection is so clear. Some of my viewers have symptoms. They'll say, "Okay, Yonit, I buy it," but I have symptoms 24 hours a day and every time I go in the supermarket, and I don't think it's because have deep childhood. Maybe some of them do, but it's such a common issue to have this visual overload or sensory overload phenomenon in supermarkets or other visually stimulating environment. For example, it seems sometimes that the symptoms the vestibular symptoms are almost a byproduct of the stress illness, and it can get really tricky for people with vestibular symptoms to figure out which things are emotional triggers and which things are just kind of a byproduct. So I'm wondering if you have any thoughts on helping people when they're looking at these situations determine, is this just symptoms that's a prediction error, my brain's making a mistake, but it's not because of an emotional issue, and which things help them figure out what emotions might lie underneath their symptoms that they need to address.
Yeah, I think when you're having symptoms, any kind of experience with your body that's doesn't fall within the range of normal, that has to be, and there's not a biomedical explanation, a
Mhm,
structural explanation, that we need to go looking for sources of stress that are, disrupting the function of that organ.
mhm,
And, I talked about, the buried emotions in that last patient's case. It was basically anger that she wasn't aware of. But there are a number of other sources of stress that are linked to what we call adverse childhood experiences.
Mhm.
And it can be emotions other than anger. It can be fear, shame, grief, guilt. I've seen all of those. They're less common, but they definitely happen.
Mhm.
It can be personality traits. People who are coping with adversity as children develop responses to that adversity that involve personality. And the most common denominator is low self-esteem, which plays out into a number of other areas. People try to be perfect as kids, thinking that if kids don't have that many ways to try to improve an adverse situation. And one of the ways that many of my patients tried to do that was by being perfect little kids. When they fall short of being perfect, they become very critical of themselves. Many of my patients as adults were extremely self-critical, much more critical of themselves than they ever would be for somebody else, for example. They try to be very good as people. They focus on the needs of others in their world, uh, and try to be productive and supportive of everybody else in their world, but they have great difficulty putting themselves on the list of people they take care of. So when you ask them, what do you do for fun? What do you do for your own enjoyment? They have to really think about it. They don't come up with very much. They if get 5 or 10 minutes of free time, they're not thinking about um, putting their feet up, grabbing a good book, pouring themselves a favorite beverage. They're thinking about, well, what can I do that's constructive or useful? And uh, people who are living that kind of lifestyle, sooner or later, it catches up with them. Nobody can exist on a treadmill that they never get off. And that's
Yeah.
been quite common. So, personality traits, buried emotions, and then finally the triggers, something in your life at the moment, a person, an event, a situation that is in some way reminiscent of past difficulties
Mhm.
that triggers you into having emotions or pain
Mhm.
or other symptoms.
So what you're saying is that it's if it is one of these other things, or there's a mix of some of these stressors that are contributing, it might not be so easy to put our finger on just one thing that's directly leading to an attack or symptoms going up. It can be a little more complicated because all of these things may be interplaying somehow.
Yeah, I mean, absolutely. My patients who, for example, um, don't know how to put themselves on the list of people they take care of. They are on a treadmill, they never get off, but the when they reach a point where that all becomes too much, can be hard to predict. I remember one of my patients whom I met um, 6 or 7 in the morning. She'd been there in the emergency room all night with acute abdominal pain. She'd been living an extremely busy lifestyle, focused on the needs of other people in her life for years. And then all of a sudden, for no obvious reason, it just became too much one day, and her body protested.
Mhm,
And it had protested with acute abdominal pain. Other people had protests with profound fatigue.
mhm,
It's your body just forces you to stop being on the treadmill, and you have to get off of the treadmill because your body insists on it.
mhm,
But predicting, when that might happen, um, it's frequently very difficult or impossible.
mhm. Right. So then we'll come back to this question then of how to try to figure out which of the factors might be affecting you, because as you said, sometimes these things are buried and hard to notice on the surface, but it seems just kind of knowing your work and knowing what many of us suggest doing here, a big clue is what was happening in your life when all this started or
Yeah,
what happened in the recent past.
when you have a sudden flare up of a symptom or a sudden onset of a symptom, it's very helpful to begin thinking about exactly what you said. What has just happened in my life? It could be an accumulation of things. You might not find any particular event or person or
Mhm,
situation that has triggered your symptoms today, for example. Um, and it might just be that issues have accumulated and they just finally reached a critical mass today.
Mhm.
But it's always helpful to think about, what stresses are going on, what has happened in today or in the last 24 hours that might have been more difficult for me than I realized.
Mhm. Mhm. Okay. So, before I start asking you questions about specifics on gastrointestinal symptoms, because I'm so excited to do that since I've been dying to get my hands on you for that answer very specifically. I was just hoping because, again, my audience, as you've seen many times, I'm sure, people often need to hear their specific symptoms mentioned so that they say, "Oh, okay, this applies to me." So I was wondering if you've seen throughout your career many folks with dizziness, not just vertigo, but just general disequilibrium or head pressure or strange visual symptoms where blurry vision or difficulties with head turns or feeling like they're walking on a trampoline or feeling dissociated. Are these symptoms that you've seen in the course of your
Yeah, I mean,
time?
absolutely.
Mhm,
Usually not as the primary reason for referring to me because
mhm,
people, in my medical community viewed me as a gastrointestinal specialist, but
mhm,
definitely many of my patients with gastrointestinal symptoms had these symptoms of vestibular dysfunction at the same time.
mhm, mhm,
And again, it's very common for people to have symptoms in more than one location in their bodies. And the more different locations that people have symptoms, the more symptoms just in general that people have, the more likely it is that
mhm.
underlying it all is a psychophysiologic condition.
Yes, yes, because when I've seen people with true vestibular dysfunction, obviously that system involves 3 senses. So it would make sense if you had some visual symptoms as well as some disequilibrium symptoms, but it usually is pretty self-limited. It's limited to specific types of symptoms. Whereas with the people that I see who have this psychophysiologic form of dizziness, I mean, it's all fair game. If they could have pretty much any symptom under the sun in any way remotely related to any sense of the body, essentially.
That's right. But what they have in common is that the physicians have not been able to find a definitive abnormality to explain the symptom.
Yes.
And if you have a symptom that your physicians have not been able to find an explanation for, then the psychophysiologic cause becomes very likely. I mean, if you just take someone who off the street who comes to see a physician just randomly, 40% of them have a psychophysiologic condition. If you then take that, all the people who come in to see a physician and you take the group whose diagnostic tests are not showing an explanation, the chances for that being psychophysiologic go way up. I mean, probably over 90%. If then the physician gives you treatment for your symptom and it's not working in the way that it is expected, the probability of it being psychophysiologic goes even higher. If you then do an evaluation looking for psychosocial stresses, stress in your life now, stress from when you were a child, um, undiagnosed depression, anxiety, or post traumatic stress, and you find those issues in someone, then the probability of psychophysiologic goes even higher. Finally, the end result of all this process is that you treat those psychosocial stresses, and if you find that the symptoms improve in parallel with the improvement in the stress, then you've got massive circumstantial evidence that you're on the right track. And the final confirmation of the correct diagnosis is when the symptom is completely relieved.
Mhm.
If you relieve somebody's symptoms by treating their stresses, you've confirmed the diagnosis beyond a doubt.
Yeah. So when you started doing this work, it was not as well accepted, at least when I say accepted, I don't mean that it's on the ground accepted, but it wasn't as well known in the literature that trauma and attachment issues and all this stuff affects us the way that it does. But nowadays, there's so much lip service paid to this idea. Oh, we know all illness is biopsychosocial, but not no one, obviously, but it's still not the mainstream way of treating this disorders. The number of people that I've seen with a diagnosis of vestibular migraine, for example, who they've literally never been asked the question, was there any stress in your life when this started? It's just shocking to me, even by people, physicians who I really respect and who generally take a very integrative approach. So my question is, as this evidence has accumulated, it's basically hitting us over the head at this point. Why is this still not widely practiced by medical providers?
That's a great question. The whole purpose of the Psychophysiologic Disorders Association is to educate healthcare professionals and the public about this. And we now have um, a number of randomized controlled trials, which is the gold standard in science, that show that new pain relief psychotherapies, of which there are several types, but they overlap a lot.
Not
When you
CBT.
Not CBT, definitely. CBT is all about helping you live with your symptoms,
Right.
and we're a million miles from that now. And that's
Mhm.
what these studies show. The Boulder back pain study took people, 10 years of chronic back pain on average. And with just 8 sessions of one of these new pain relief psychotherapies, the pain scores dropped from over 4 down to about 1. Two
Mhm.
thirds of their subjects got down to 0 after 10 years of pain. And then they followed them for a year, 11 months after the end of the psychotherapy, and the pain scores stayed down. And the two control groups, they dribbled down a little bit below 4, but that's as far as they got. So there was this massive separation between the psychotherapy group and the two control groups. And there are now several other studies that show the same thing, that if you pay attention to emotions, you pay attention to past life stresses, childhood stresses, that you can achieve these dramatically better outcomes.
Mhm.
But that's what it takes to change medical practice, is you have to demonstrate it with gold standard science and then get the word out to everybody. But
Mhm.
it's a challenge because it's a completely different way of thinking about disease, where we physicians are all trained about physiology and structures and organs, and now all of a sudden we have to talk about psychology. And most of our patients with psychophysiologic disorders don't look particularly stressed out. People that I've seen who have been coping with massive levels of stress, if you didn't ask them about it, you'd never guess. I mean, these are people who
Mhm.
could be your neighbor, your coworker, people that you know socially, and you'd have no idea the level of stress that they're coping with, and unless you do what I do, which is what I call a stress evaluation, where I go step by step through all of these issues, and people tell you these unbelievable stories that, if again, if you knew them socially, you'd never guess that they were coping with this. And I think that
Yeah.
that puts physicians off as well, as they look at a person like this and they say, well, this person doesn't seem to be all that stressed out. I'm not even going to ask them.
But I feel like that's part of these folks' calling card. I often tell people, because they say, "Oh, you're saying I'm not resilient to stress. I can't handle stress." No, on the contrary, you handle stress too well. That's your problem. You internalize all that stress. You're the great handler of stress. So, like you, the people that I see are particularly put together, successful, high achieving people, and
Yeah.
that's actually part of the story and why they ended up with one of these psychophysiologic disorders.
They are Olympic champions of stress management, but a
Yeah.
lot of the time they feel like they are failures at stress management, and the reason is that they're carrying 200 pounds of stress around that the rest of us don't have, and they feel like, gosh, what's the matter with me that I can't handle this extra 200 pounds of stress?
Hmm.
And when they put the stress down finally, they realize what heroic perseverance was needed to endure everything that they've had to endure up to that point. And I want
Mhm.
my patients to think of themselves in those terms, like um, analogous to somebody who's climbed Mount Everest, or who was born in the middle of a dangerous wilderness and somehow found their way out. That's what it's like coming out of an adverse childhood experience environment in many cases. And
Mhm.
people should think of themselves as heroic for what they've done, and turn that low self-esteem, which is so common, into a positive. Think of themselves as, as I say, like somebody who's climbed Mount Everest, who was born on the far side of Mount Everest and had to climb up and over to get to the other side. That very first patient that I mentioned, her father had sexual intercourse with her an average of once a week from age 4 to age 12. It's, to this day, one of the worst stories of sexual abuse that I've ever heard. And she um, was living a very positive life. She was happily married. She was well thought of in the workplace. She had two
Mhm.
kids who were doing well. You'd never guess that she was carrying that kind of burden around um, un, until you asked her. And she deserved to think of herself as incredibly heroic. And it's part of the treatment of this condition to help people see themselves in what are really just realistic terms, that through no fault of their own, they got this huge stress, and they should give themselves credit for having carried it so long.
Mm. Beautiful. And, I'm so happy to say that Christy Weepy of the Boulder Back Pain Study, she was one
Yes.
of the yes, she's gonna be coming onto my channel specifically to talk about self-compassion. So we're gonna be covering that in a lot of depth here soon too.
Yes, all your patients should watch that one.
Yeah. Yeah, every single one of them needs to hear it. So coming back to the Boulder Back Pain Study for just a moment, though. So you mentioned there's this need for randomized control trials to start changing medical practice. So this is really more me asking your opinion based on your clinical practice. I know we don't have the randomized control trials right now, but from your perspective and your experience, vestibular disorders with that are symptom based, that are not the cause of that not caused by biomedical issues or tissue damage, do you view those as psychophysiologic disorders that should be
Yeah,
treated the same way?
yeah, absolutely.
Mhm.
Whenever there is a symptom that has no structural cause, no organ cause, um, then a stress evaluation should be done.
Mhm.
Any stresses that are uncovered should be treated.
Mhm.
That's the diagnostic process. I'm not saying that we can guarantee that every single non-biomedical symptom is going to respond to this, but
Mhm.
a very large fraction of them are going to respond to this. And when they do, that gives you additional evidence that you're on the right track.
Mhm. Okay, thank you. I think that's gonna be very meaningful for people here to hear. And this is one of my great crusades now, is to get the word "and dizziness" added to all the books and all the websites that talk about pain. Pain, and then in parentheses, "and dizziness," so that people understand it's really part of the same complex of psychophysiologic disorders.
Yeah, absolutely. It's tinnitus as well.
Yes.
In many cases, we can't, guarantee that it's every single one. No responsible physician is going to use words like, every or always,
Mhm.
but it's a lot. It's definitely a lot.
Mhm. Okay. So, would it be alright if I ask you some questions about gastrointestinal issues specifically?
Yes, I will be glad to pass on what I've learned from my 7,000 plus patients.
Yes. All right. Wonderful. So, uh, this also is something of personal interest to me because, as you know, all of us practitioners come with our own mind body story, and gastrointestinal symptoms were one of my major symptoms. So, but this is something I hear from many clients who actually often don't make the connection at all until I ask about it. But this is, I would say, probably the second most common set of
Mhm.
symptoms in people that I see. So, can you give me an idea, first of all, of what types of symptoms and what types of diagnoses would be included under this umbrella of psychophysiologic gastrointestinal disorders?
Yeah, well, the simplest answer is just about anything short of hemorrhage or, you know, large mass in your abdomen.
Mhm,
A large number of cases of acid reflux or laryngopharyngeal reflux. Not
mhm,
all of them,
mhm,
certainly, but a lot of them, especially the ones that don't get better with a proton pump inhibitor medication.
mhm,
But nausea,
mhm,
vomiting,
mhm,
bloating, diarrhea, constipation, rectal spasms,
mhm,
abdominal pain,
mhm,
uh, what's called irritable bowel syndrome. Um, and the abdominal pain can be over the entire abdomen. It can be just in one place. It can be
mhm,
a very small area. Actually, the smaller the area that's painful, the more likely it is to be psychophysiologic.
mhm,
It can move from place to place. The pain and the more abdominal pain tends to migrate, the more likely it is to be psychophysiologic.
mm,
So it's almost every symptom that I saw in my practice, again, short of tumors and bleeding,
mhm.
um, could have a psychophysiologic cause.
Okay. And what are the typical diagnoses these patients are given when medical causes are ruled out?
Usually it's labeled irritable bowel syndrome,
Mhm,
and you'll sometimes also hear terms like idiopathic or cryptogenic, and those two terms basically mean the physician doesn't know what's causing your symptom.
mhm,
But irritable bowel is a collection of symptoms that tend to co-occur with each other. It can be um, abdominal pain, bloating, gas, diarrhea, constipation, or diarrhea alternating with constipation, depending on
mhm,
whether the gastrointestinal muscle contractions are propulsive or not propulsive.
mhm,
But that's typically what you'll hear. Then you have functional dyspepsia or non-ulcer dyspepsia, and then there's acid reflux, which in many cases is actual acid reflux coming from the stomach up into the
mhm,
esophagus or even higher up into the
mhm,
throat. But other people can have uh, very similar uh, pain with that. Often, pain in the chest can be having a burning quality or not.
mhm,
And when it doesn't respond to a proton pump inhibitor medication, which is usually very effective for acid reflux,
mhm,
then the probability of it being psychophysiologic goes up. There are
mhm,
people with acid reflux who, real acid coming up that don't get better with a PPI medication.
mhm,
But if the PPI is not working, then definitely that patient should get a stress evaluation
mhm,
and treatment of any psychosocial issues that are found.
mhm. So it's interesting because not to say that pain doesn't sometimes have physical consequences, but the symptoms you're describing often have very tangible outcomes. So, especially the lower gastro issues, I mean, people are actually having diarrhea or actually having constipation. So, is what's the what's the psychophysiologic explanation for why this happens? Why it's if it's not just, oh, I feel pain in my body, when it actually has a physical consequence, what's happening in there?
Yeah, well, psychophysiologic symptoms are have their origin in the brain. The analogy that I'll make with my medical audiences is to phantom limb pain. Phantom limb pain is a phenomenon where a person feels pain at the site of a limb that has been amputated. The
Mhm,
limb is no longer there, so it can't possibly be the cause of somebody's pain, but they feel pain as if that limb was still there. The
mhm,
only place that pain can be coming from is the brain. And in psychophysiologic disorders, symptoms are generated in the brain. There are studies now that show anatomic changes in the circuits in the brain that are responsible for this.
mhm,
And the gastrointestinal symptoms occur the same way, that there is something going on in the brain in reaction to stress that is resulting in signals coming from the brain to the gastrointestinal tract and causing muscles to contract in ways that they normally would not. If they contract in a propulsive way, you get diarrhea. If they contract in a non-propulsive way, in which basically they just spasm and don't move things along, then you get constipation. It can happen in the stomach as well. One of my patients, we actually had a test of his stomach emptying done because he presented to the hospital with repeated vomiting, and it turned out that his stomach was completely paralyzed. It's called a gastric emptying study, and in his case, the stomach didn't empty at all, completely paralyzed. And that's unusual, but we know that it was happening 100% because of its signals from his brain, because when we uncovered the stresses that were responsible, he got better. His symptoms, which he'd been having off and on for 7 years, completely resolved. So the brain can do some pretty profound things. I mean, that very first patient, one bowel movement a month. I mean, that was obviously an example of non-propulsive contractions of her large intestine. That is a really profound disruption of your normal physiology. And we know that it was all brain generated because she got better with about 10 sessions of psychotherapy.
Okay. So from your perspective then, whether someone has dizziness or other vestibular symptoms or some of these gastro symptoms, the bad news is that they're suffering, but the good news is really the way to address them is exactly the same approach. We need to uncover the stressors that are
Yeah,
leading to this issue.
the stressors have changed the circuits in the brain, and the brain is then causing disruption in the normal function of these organs. So we have to trace it back to the roots, which is the stress. And when we do that, the outcomes are much better. And again, these symptoms are 100% real. I mean, that patient who had the paralyzed stomach, we could see it right there on the test. And the patient with the one bowel movement a month, the tests that she had, again, showed profoundly disrupted physiology. So there is nothing imaginary about these symptoms. They are not in your head, quote unquote. They are brain generated by neuroanatomic circuit changes.
I'm so glad you said that, and this is why I'm so excited to be talking to you, because this is so much more like dizziness than some of these other also similar but a little bit different psychophysiologic disorders. Because my personal theory on these vestibular disorders is people are truly having vestibular dysfunction. It's just that the source of the vestibular dysfunction is a reversible physiologic process that's resulting from stress. But it's not just, oh, I have a circuit that's imagining dizziness. It's that there really may be a temporary physiologic change that's leading to these symptoms.
Yeah, the Boulder back pain study actually showed that. They did functional magnetic resonance imaging of the brain before and after treatment, both the psychotherapy treatment and the control group placebo treatments. And they found that the patients who got the psychotherapy, their brains were physically different as a result of the psychotherapy. And this was hinted at in a study of a single case of irritable bowel syndrome that was published in 2003. Very severe symptoms this patient had, and they scanned her brain, and then they scanned her brain again after she got psychotherapy, and her irritable bowel improved, and the brain was different. I mean, she had, the neuroanatomic circuits were neuroplastic, which means they're capable of change in response to treatment. So not only is the illness physiologically based, but so is the treatment.
And I'm happy to hear you drive this point home, because in my world, in the vestibular world, there are these studies coming out where researchers are trying to find the biomarkers of some of these symptom-based disorders, and they have these alarming headlines that will come out. Brain changes found in in people who have diagnoses of triple PD. And I tell people that's like me having a hurting hand and you say, yep, you have hurting hand syndrome. It doesn't mean anything. It's descriptive. It doesn't mean that, you have some brain damage that's causing the symptoms. Of course, you have altered brain function if you have symptoms, but that doesn't mean it's not reversible. It's just this is the way your brain is functioning right now. What they're doing is describing what the brain looks like when you have symptoms. It doesn't mean that that's the source of the symptoms.
Yeah, it's an example of how we physicians are trained is to keep looking for a biomedical cause.
Mhm.
And, you know, y- there's no substitute for having conversations with people about their lives, and just listening to what they say when you ask them about stress, past or present. I mean, this was what was so shocking to me when I started out in this field was uh, the patients who had normal diagnostic tests. They would come in to see me for a symptom. I would do the tests that were indicated. They would be normal. And so I had been trained by Dr. Kaplan of what kinds of questions to ask, and thinking that, most of the patients that I ask these questions, they're not going to have any issues because they don't look like they have any issues.
Mhm.
They're not coming across to me as extremely anxious. They're not pounding the table. They're not pacing back and forth. They
Mhm.
they look just like anybody else.
Mhm.
And so I would ask the questions that Dr. Kaplan had taught me to ask, and patient after patient after patient would tell me these unbelievable stories of that 200 pounds of stress they were carrying around that nobody knew about. It was another level of shock early in my career.
And it like you've said, it's sometimes so healing for people even just to be able to talk about it. Sometimes they just need to make that connection between the stress and the symptoms, and that reduces that danger signal, that that automatic brain response that's leading to the symptoms.
Yeah, and I should add that a lot of times people look back at their childhoods and they don't necessarily recognize how difficult their experience was. Many of them will say, at least initially, things weren't that bad. There were a few things, but they weren't that bad. And it took me a while to recognize just how much of a burden could be placed on kids without their fully recognizing it. I mean, one of my patients told me that, after we'd been talking for quite a while, he just
Mhm.
remembered that the only time he ever got praise from his parents was when he did something better than his brothers and sisters could do it. And he had three siblings, all
Mm.
of whom were very accomplished, academically, socially, athletically, and so on. So doing something better than they could do it was really hard, which meant that he hardly ever got any praise or support or was made to feel good about himself. And so
Mhm.
he came out of his youth with this same burden of low self-esteem, feeling like a failure, even though he had done really well. He just hadn't always exceeded the level of achievement of his siblings. And so he felt like a second rate human being. And he carried a huge burden of that with him that had all kinds of secondary effects in his life. He wasn't very assertive. He would be extremely self-critical, and a number of others that eventually created enough stress to make him physically ill.
Mm. And
But
so
it was a
yeah, go
fairly
ahead.
subtle
It's subtle.
adversity. Yeah.
Yeah. Thank you for saying that too. Because again, as you've seen, we have a very high proportion of people who score high on the adverse childhood experience questionnaire, but many of my clients had wonderful childhoods and have gone through years of psychotherapy in many cases. And when I start talking to them and we uncover some of these more subtle adversities, it's the first time they're ever talking about them because on the veneer was so good. It looked so good. Their childhood looked so good from the outside. They didn't even have any awareness that there was some deep stress involved there that was really accompanying them for the rest of their lives.
Yeah, one of the questions that's been probably the single most helpful in my practice has been to ask people to imagine themselves a butterfly on the wall of their childhood home, and they're watching their own kid try to cope with what was going on, that their own kid is living through exactly the same experiences that the patient did. And what is it like to watch that happen for a week or 10 days?
Mm.
And it's a completely different experience for a person to look at their own childhood with all the emotions likely suppressed around that experience, and then to look at a child of their own or a child whom they care about living through those same experiences. I see very commonly person's facial expression completely changes, and people say, I would never in a million years want my kid to go through that, or I would never raise my kid that
Mhm.
way. I would do all these things differently. And they
Mhm.
finally start to see that things were tougher on them than they previously knew.
Mhm. I think that's one of the questions, if I'm not mistaken, in the questionnaire on the PPDA website.
Yes.
Yeah.
Yeah. Number
Yeah.
37.
Yep. 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 Would you want your child to have had your childhood? Right?
Yeah.
Yeah. Okay. So I'm curious. So I have a few just curiosity questions following up on some of the things we've talked about. The first is, do you have any thoughts on why so many people have their symptoms manifest in the gastrointestinal tract? Do you think there's any symbolism or any reason for that? Or is it just the luck of the draw or some biological factor that seems to lead people there?
Well, the nerve connections are very strong. I mean, the gut has somewhere in the range of 5 or 10% as many neurons as the brain does. So it's extremely well wired. It's even been called a second brain.
Mhm.
And it's very strongly connected via the vagus nerve to the brain. And anybody who's ever, felt a knot in their abdomen when they were in a tense situation knows that there is a connection between the brain and the gut.
Mhm.
And it's very strong. And the
Mhm.
reason is that when we are in fight or flight mode, we don't want circulation going to our gut. We want the circulation going to our muscles so that we can fight or flee. And so we have to have the sympathetic nervous system shut the GI tract down so that the body's resources can be diverted to where they need to be in that tense situation. But if you are always in a tense situation,
Mhm.
then you've always got um, nerve signals going to your GI tract, and they can cause symptoms.
Okay. That makes a lot of sense. Okay. So in that case, do you think that that explains some of these food sensitivities that people describe accompanying these symptoms? Because I question whether they're true biological food sensitivities in the sense that they were born with them, or if they are perhaps another prediction error related to a compound that, again, is maybe the gut is misreading as a source of danger, or it's become overly sensitive to certain types of foods because of these other nerve signals coming down from the brain.
Yeah, what often happens with that is that a person will get a gastrointestinal symptom. And when they do, instead of looking for a stress that is responsible for it, they will start thinking about what they just ate
Mhm.
and they will blame that. And it isn't unusual for people to come and see me and say they've got this long list of foods that they're sensitive to. But when you ask them in more detail, it turns out that those foods only cause problems some of the time. And that in fact, what's going on is that they are misattributing the symptoms to the food. And it's not really the food, it's just that the stress caused the symptom and then they blame the food for it. So only a small fraction of people who believe they have food allergies or food sensitivities actually do, especially if they've been tested for celiac and the tests are normal.
Thank you for saying that. And I'm wondering if you feel that the same process applies to migraines, because my clients, again, many of them have a migraine diagnosis, even without again, it's symptom based, right? And they're told to go through these elimination diets and try to find their trigger foods. And, they swear up and down that they have attacks that are associated with eating particular foods. Do you think that same logic applies there?
I think it probably does in a lot of cases. If you have a food that gives you a migraine 10 times out of 10, then I'm probably going to be convinced.
Mhm.
But if it gives you migraines, 5 times out of 10 or even 7 times out of 10, I'm not going to be convinced. I'm going to be leaning toward the idea that the migraines are happening in reaction to stress or happening just randomly, and you're misattributing it to the food.
Mhm. Well, and then there's this whole idea too of brain prediction error in which just believing that a food might be your trigger can also be a contributor to the actual symptoms happening as the result of the food. So it
Yeah,
could also be a factor.
that's I'm sure active in some people.
Mhm. Okay. So bringing this all together for people then. So if someone is dealing with mind body symptoms, again, on my channel, it's going to be primarily dizziness, but many of them have gastrointestinal symptoms too. What's they already understand the idea of a mind body disorder, because if they're here, they probably do. What's their next step then? How can they start to identify what some of these underlying causes may be?
Well, when I'm seeing a new patient, like I say, I do a stress evaluation and I'm looking for stress in a person's life at the moment. I'm looking for childhood stress, which again, sometimes can be not so obvious.
Mhm.
And I'm wanting to make sure that there's not any depression, anxiety, or post traumatic stress. But
Mhm.
people who have the most severe symptoms, which is probably the group that finds their way to you,
Mhm.
there is almost always a childhood stress component. And the long term impact of adversity in childhood manifests in personality traits, in unrecognized emotions, and in triggers by people, events, or situations that are going on in the present day. And if we can identify all those things and work on them, then symptoms usually improve.
Mhm.
One of the best things you can do for the buried emotions, which tends to be the most difficult single issue to address, is to do that exercise of thinking of yourself or imagining yourself a butterfly on the wall of your childhood home and watching a child you care about try to cope, and then writing about the emotions that come up, or writing an unmailed letter to the person who mistreated you, where you put your thoughts
Mhm.
and feelings down, or an exercise that Dr. Schumacher has people do, where they imagine a difficult person or situation and write furiously words and phrases that have to do with that person or situation for 5 or 10 minutes, without caring about grammar or syntax or even sense. And then after you get all those words out, spewed out onto the paper, then look at them and start writing complete sentences to try to make sense of what you've just written. It's a way to tap into these buried emotions that can be responsible for symptoms. So a lot of techniques. Endchronicpain.org, the website of our nonprofit,
Mhm.
has lots of good resources. The Curable app is wonderful. They people who created that have reeled in some of the best national and international experts in this field, and taken all of our best ideas and put them into a uh, really excellent user interface.
Mhm.
That's helped a lot of people.
And
Uh,
equally applicable to dizziness and to gastro symptoms, even without pain.
that's right. That's
Yeah.
right. You just have to substitute your symptom for the word pain, and all of these ideas apply.
Mhm, mhm. Wonderful. Okay. Thank you. That I think this is gonna be tremendously helpful for people to hear. Anything else? Any other words of advice to people who are dealing with these issues right now?
I would just give everybody hope. I have seen patients who were in real extremes of illness who have made full recoveries from this. I mentioned the woman with 79 years of illness. Another one was a man of 55 years of illness. Another one was a 17-year-old girl whom I was asked to see on her 70th day in the hospital, getting 250 milligrams of morphine per day, around the clock. 5 or 10 milligrams of morphine is enough to alleviate the pain of a fractured leg. She was getting 10 milligrams every hour. I was her 7th gastrointestinal consultant over the previous 18 months. That patient made a full recovery in about 30 days. Not everybody gets better so quickly. I don't want to raise, false expectations. I've had other patients that, as I say, needed years of psychotherapy. But even those patients, they could see they were on a pathway toward improvement and recovery. And there's great reason for hope with this condition.
Thank you. That I could think of no better way to finish our conversation today. I really, really appreciate your time, and thank you so much for coming on.
Thank you for everything you're doing, Dr. Yo.
Oh, thank you, Dr. Clarke. I wouldn't be doing it if I weren't walking in your footsteps and Dr. Schubiner's footsteps, Dr. Schechter's footsteps. So thank you for leading the way.